So here's the funny thing, funny to me. So the patient's telling you, I mean, in their mind, they're convinced it's tennis elbow because the doctor said so. In their mind, they're talking about the gripping part of the activity or the elbow extension part of the activity, like the gentleman, I think you were here for this guy. His wife was in therapy like forever, and then he got referred. So he's telling me about the gripping and the elbow extension. He did power wash in his house. And he's saying gripping and elbow extension, and I'm like, yeah, you're power washing the house. You know, so his was levator, and I never convinced him, but he's one of the few. I'm usually very convincing. Okay, so as I said, occasionally it's really cool, and actually this happened when one of our PT Army Baylor students was spending the day with me, because you know, those PT folks, especially if they went to the Air Force Academy and Army Baylor, I mean, I'm just amazed that they could even hang out with the likes of me for a whole day. But this one particular lady, I was just so sure, and I poked on that levator, and she's like, ow, how did you do that? And so, you know, he went and told all of his other PT classmates, and you know, really smart that day. Okay. So, straightening the lordotic curve. So, does everybody know what the normal curve looks like? I mean, I get to look at a lot of x-rays, or I did, because we could actually view x-rays at our desks at my last 2 assignments. Usually it's going to kind of curve forward about here and then back. This one, of course, does not. And in fact, this one I would say is more than just straightened. This has actually got a retro curve. Can everybody see that? It has retro curve like right through here. Okay. So this is what happens when. Well, let me ask you. You go to the emergency room. You had a car accident, and they say, "Oh, you got whiplash." What does that mean? And how do they know? Why do they say that? How do they come up with the diagnosis of whiplash? You had a car accident, you said your neck hurts, must be whiplash. Maybe, yeah, they really might do that. But a lot of times they'll do an x-ray, and they'll say, oh, look at this straightening. You know, so there's nothing wrong with the bones. We can't tell if anything's wrong with the ligaments or not from an x-ray, but they see this straightening in the lordotic curve, and they say, oh, whiplash. Well, guess what? That person may have had straightening of that lordotic curve for 5 years. Okay? From, you know, desk work or from whatever life threw their way. But that's one of the findings that you might see. And this one, okay, everybody see this straightening? Okay, and let me tell you, this is very good. This x-ray was read as normal lordotic curve. So most of the time the x-rays would just say, what the radiologist does, he didn't actually say normal lordotic curve, he said code for normal C-spine. And that's just one of the little blurbs that goes into the blurb for normal C-spine. But yeah, I always look at the x-rays myself. Because I would say, I don't know, would you say it's fair that at least 30–40% of our straightened lordotic curves were read as normal? I mean, that might be very conservative even. Okay, how much time we got? 15 minutes, how many slides I got? I'm on 100. How many I got? Okay. Okay, I really got to hurry here. Okay, so these are some of my assessment statements. Okay, and they're also on the 4-page handout with my eval. This is also part of it. Okay, so you know, I mean, I see, you know, in my experience, you know, I see this a lot, blah blah blah. Be brave. After you collect the experience. Okay, so again, we're going to treat the distal symptoms. Okay, even if I'm convinced it's your levator, if your wrist hurts and you can't grasp things, I'm going to treat you like, you know, a de Quervain's protocol, which basically, though, I mean, you can't keep lifting and grasping and expect it to go away as if by magic, right? So I'm pretty hardcore on my de Quervain's and my tennis elbow protocols. I tell them, you know, red splint 24 hours, you know, 24 hours a day, 7 days a week. You take it off for hygiene and don't lift anything heavier than your pen, your pencil, your car keys until I tell you can lift heavier. Icing 3 to 5 times a day. You know, NSAIDs, I've kind of gotten away from drugs and such. You know, if you're into the natural world, you know, you can tell the patient, ask your doctor if he minds if you try some arnica from Sun Harvest instead of some you know, Motrin to kill your kidneys or some Tylenol to kill your liver. Okay, I did an ergonomic computer workstation class like twice a month for 2 hours, and I did usually once a week or every other week I did like an hour treatment plan education group where I really talked about the rationale for wearing the splint, for icing and whatnot. Again, that was to gain compliance, but also, you know, in your busy life with your life stressors, you know, you can kind of figure out which, if you know the rationale, then you can kind of make some, you know, some decisions and prioritize. Because, you know, this guy, I mean, I can't answer your question, you know, 24/7, so kind of empowering the patient. You know, progression. So this was actually, yeah, for lateral left and elbow. Okay, so now, so the treatment. Okay, so the treatment for the proximal etiology. Okay, so you do the distal stuff, and then again, I tell them to at least try icing to the neck, upper back. And I don't say it, you know, nicely like that. I mean, I really hammer it. You need to at least try it. You would be surprised how many of my clients find that they can relieve their elbow pain by icing their neck, upper back. Trigger point release. This would be, you stand up again, I promise not to hurt you, we'll just pretend. Okay, so turn around. Okay, so I'm going to find lateral border, and here's the scapular spine. So here's your levator there. Does that feel nice and tight? Okay, so I'm going to look for like ground zero, that area that is the, he'd have to sit down because obviously there's a height discrepancy here. So I'm going to find the area that's the most tender, and then I'm going to warn you, okay? I'm going to press in, and I'm looking for a discomfort level of about a 7 of 10, but it's only for about 60 to 75 seconds. The area will be really sore. You might possibly even be more achy tonight, but tomorrow, I promise you, you'll get at least a little bit of relief of these symptoms. Okay? And so, if you do not collapse into hyperextension at your thumb like I do, you can use your thumb. I kind of tend to use 2 fingers like this, and then kind of give them a little help and press down. But you're trying to hold really steady, constant pressure for 60 to 75 seconds. Most patients actually get instant relief, but lucky me, I never do. But and actually for me, you can sit down and I'll probably back up again. Huh?
At the base of the levator?
Whatever part of the levator seems to be ground zero, whatever seems to be most tender or most knotty. Because for me, myself, sometimes it's more towards the scapular insertion, and sometimes it's much more towards the skull. It just depends. I've tied myself in macrame here. Okay, positional release. Now here's a cool thing. I've never had anything done to me but this trigger point release. And so I go in one day because I'm having really exquisite sharp pain at my wrist, but I know it's not the cord veins because it comes and goes. And I go tell my boss, the PT, please, 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 please do a release on me because I've got to finish these reports, and I mean, I didn't want to wear a splint for Pete's sake. That wasn't going to help me get the work done. So I'm expecting this trigger point release, and he did something that didn't hurt at all, and it actually made it better. A positional release, so most of the time you're going to be lying down. I actually took a course on this through, what's the name of the one? Cross Country. And it was a massage therapist, and it was called Treat the Neck Gently. And so one of the strategies of positional release, like I might have you lie down on the table. I might actually have you come to the end of the table where your head's hanging off and I'm holding your head. Now, I'm not proficient enough to do this by myself. I need one more arm. But I would like hold your head and move your arm, and then you're kind of like tapping the spot to kind of monitor. And what we're looking for is that combination of movements where you say, okay, the symptoms have disappeared. So that position we're going to hold for like 60 to 90 seconds. And so it's taking the stress off the muscles. Intuitively, it should be the position of slack, but this thing doesn't really work that way. Myself and patients that I've worked with, sometimes it's like a weird screwy position, like you got your neck way forward like this. But you just kind of keep moving the head and neck until you find that spot, that sweet spot where they're pain-free. And so for whatever reason, that is putting slack on something that needs slack, and you do that in 60, 90 seconds. It's a little harder to do, you know, the poking on the trigger point, that's really easy, but, and you know, most people are game. I mean, who couldn't stand a 7 of 10 pain for 60 seconds? It's going to make you better tomorrow. Another thing you can do is combination ultrasound and E-stim. Again, one of my favorites. Anybody familiar with that? I mean, you work in PT clinics where, or with PTs where, I don't know, in the Air Force we could just do it. mean, we just did it because our technicians were cross-trained for OT and PT, and they just wrote in the treatment plan, they just did it. But I don't know, that might be a problem with some of your clinics. I don't know. You think it would be a problem?
No.
No? You think?
A lot of people don't know how to do it. So might have to
Yeah.
10 minutes.
10 minutes, okay. So now, I always start out with the chest opener stretches, because it's already a pretty overwhelming treatment plan, and that's why you really need time to explain these things to patients, because most treatment plans are just a really long, inconvenient list of do's and don'ts. So you really need to explain the rationale as much as you can. But I start with the chest stretches, and I tell them, you know what, try to habituate this. So like maybe at the top of the hour, you do the chin retraction, and then you forget to do anything else for the rest of the day. But tomorrow, you remember to do the chest opener in the morning and the side stretch in the afternoon. And, kind of keep going to where you've kind of habituated this, where you just kind of do, 5 repetitions of 1 or 2 of the stretches and spread it throughout the day. And most patients do say that they are successful in doing that. So once they've habituated that, so now we're re-lengthening all these short muscles to the front. And so now the trick is to start strengthening these neck, upper back muscles, okay? And so just quickly, if you don't know what these are, find a PT colleague. Rowing action, and you don't have to have a machine, and you don't have to have weights. You can just row away, okay? So you're working on like your middle lower traps and your rhomboids, right? Okay, and then IYTs. So this is your capital I, and you kind of go backwards. And again, I would start out with no weights at all.